complaining of numbness in his right hand and difficulty in buttoning his shirt for the last 1 month. He has been wondering if it could be due to him playing golf quite recently, which he does that for about twice a week. So there's 3 questions to be discussed. Firstly, we are supposed to discuss the differential diagnosis and further history which we would like to obtain from him, and what sort of physical finding which we would like to look for, and how will we manage him, and when will we refer this patient. So let's start off with the differential diagnosis. We are going in terms of top down. First of all, we think of could there be any brain pathology such as a stroke, small lacuna infarct? Could there be a sort of a mass tumor infection in the brain that is causing such a symptoms? Next up, we could think of something that is happening in the spinal cord, such as a cervical myelopathy or any demyelinating disease that can be causing the symptoms. Further down, we can think of any brachial plexus pathology, such as lower plexus paralysis, injury to the C8 and T1 region, which could cause the weakness of finger flexion or any weakness within the intrinsic muscle of the hand. These are usually associated with trauma or a mass such as a Pentecost tumor causing a compression of the nerves. The other possibility that we should consider would be peripheral neuropathy. So more towards systemic causes such as polyneuropathy, causes such as diabetes, alcohol, B12 and folate deficiency. If there's any metal poisoning, we should also consider if there's any isolated nerve injury such as a radial nerve, ulnar nerve, or median nerve injury that can be causing such a symptoms or presentation. There are also possibility of other diagnoses such as Parkinson, ataxia, neuropathy, but the group has decided that we will focus more on these 3 diagnoses, which is the carpal tunnel syndrome, cervical myelopathy, and also we would like to rule out, make sure that it is not something like a peripheral neuropathy. So first of all, we like to go through the whole history with the patient to make sure to have a better understanding of what he has been experiencing. So we'll go through in depth of a comprehensive history, make sure we take his past medical history, because that can predispose him to certain conditions, any surgical history, any previous stroke or any neurological diseases, any family history, any drug allergy, what is his occupation history, because he's quite elderly. When he's younger, he could have been a construction worker or something like that, or pianist, which has been using his hands a lot. Any other social history which could affect our risk stratification of this patient. So in terms of presenting complaint, we would like to know what is the distribution of the numbness of the hand. Is it only one hand, both hands? Which part of the hand is affected? Is it the dorsal or the palmar surface? How many fingers? What is the actual distribution of the numbness? We'd like to know the onset. Is it a sudden onset over the last few days, or is it a chronic thing, or is it a gradual onset, gradually getting worse over the last 2 months after playing too much golf? We have to know the timing, or is it of the numbness. Is it on and off? Is it continuous? Is there previous episode of such symptoms? Anything that makes it better or worse? Playing too much golf make the symptoms worse, or at a certain position then it triggers and he has the numbness on his hand. Is there any other associated symptoms such as difficulty writing, holding a pen, any paresthesia, any weakness of any part of other body parts? Any other focal neurological symptoms, any neck pain, how's his gait, any cord syndrome, any urinary incontinence, any constitutional symptoms, any infection, or any recent fall or trauma. In terms of the physical examination, we would like to think about is it an upper or lower motor neuron lesion, or we are trying to do certain various neurological examination to try and elicit any upper motor neuron signs such as hyperreflexia, the Hoffman sign, positive Babinski, and any sustained clonus. We will try to look at the hands on the affected region, look at the hands at the tena and the muscle groups, look at the tone of the finger, check the reflexes of both the upper and lower limb, check the power groups of the various muscle group of the upper limb and the hands, the sensation and proprioception. We can also perform various maneuver and tests such as the Tinel test and the phalanx maneuver to check for a diagnosis of the carpal tunnel syndrome. We can also look for any neck stiffness, neck pain, reduce of neck movement if we are considering the diagnosis of cervical pathology from the neck. Because our main proposition for this case is actually we think that it's probably carpal tunnel syndrome, we would like to have a more in-depth examination of the various nerve of the hand. So for example, if we like to fully assess the median nerve, the motor innervation of the nerve, we can test it through the adductor pollicis brevis, whereby we can assess that muscle. And then if there's a weakness in that muscle, then it would probably shows injury or suggestive of a median nerve injury. And then for the ulnar nerve, we can check for the first dorsal interosseous muscle. And then the interpretation of this examination would mean that if it's an APB alone weakness, then we can consider a medium nerve injury, while a first DI alone weakness could be a ulnar nerve injury. But if both of them are weak, then it's probably a T1 radiculopathy. So in terms of management, if the history and physical examination is suggestive of carpal tunnel syndrome, it will be based on how bad or the symptoms is. So if the patient have very mild symptoms of only just numbness with no significant sensory loss or weakness of the muscle group, especially over the median nerve, then we could just try some conservative management. So avoiding repetitive action of the wrist, can consider having some oral topical glucose injection, steroid injection to the wrist, refer the patient to the OT, having some nocturnal wrist splinting, all this can be considered. But if the patient is having very severe symptoms or failed conservative management, then we should consider referring the patient on. If the history and presenting examination suggests a cervical myelopathy, then we should consider doing an X-ray of the cervical spine and even considering MRI and referral to a specialist. If it is more suggestive of peripheral neuropathy, then we should do some blood tests to make sure that if there's anything that we can correct, we should do it. So we should do something like a full blood count, renal panel, fasting blood glucose, B12, thyroid, ESR. Then if the initial screening is negative or the symptoms are very persistent after we try to treat any abnormalities, then we should consider doing some nerves conduction studies. There are also other special tests we should consider doing, such as HIV, syphilis, vasculitis screen, drug or metal poisoning. But all these are usually quite rare, not very commonly seen. In the meantime, while we are treating the patient, we can also consider starting a patient on some neurobion supplements that might not help with his or her symptoms. If it's really a lot of neuropathic pain, then we can consider trying some gabapentin or pregabalin. So when do we actually refer? So as I mentioned previously, for carpal tunnel syndrome, if there's any strong evidence of any median nerve injury or loss of the function, then we should refer, or we should refer when patient wants very instantaneous recovery, such as they want surgery, more or less, or there's a failure of non-surgical therapy. For cervical myelopathy, when the X-ray is very abnormal or when the MRI shows cervical myelosmia, then we should refer spine for any decompression. So for peripheral neuropathy, where we cannot manage, irregardless of trying to fix all the abnormalities where we find, or if the EMG or NCS shows demyelination or any axonal loss, then we should refer neuro. Or if there's any suspicion for any autoimmune disease or abnormal inflammatory markers which we cannot explain, then we might need to refer the patient for a workup by rheumatology. I think that's more or less what my group have prepared for this session. Is there any questions that we can help and answer?
Okay, thanks, Shu Heng. I thought it was a very comprehensive presentation. Before I hand over to Dr. Ramani, maybe I might want to ask something regarding your referral criteria, if you could go back to that. So I think probably the question is also to Dr. Ramani is when we refer for carpal tunnel syndrome, will we want to wait until the patient has severe CTS? And how would the prognosis be? Or should we refer when the patient is still mild but failed conservative management? So that's probably one of the things that we might want to think about as we monitor the patient. Secondly is this part about cervical myelopathy. So I think in our setting, it's probably difficult to send patient to MRI. And when will we actually refer to a neurosurgeon or spine for decompression? Will it be at a point whereby the patient has myelomalacia, or will it be at a point whereby there are certain signs or symptoms of compression? So I think it's mainly we're talking about when is the appropriate time to refer for these two conditions. So it's something that we probably have to be clear about as well. Then I think some of your colleagues have been asking some questions. So I think one of the things that in general is that when you are given any stem for GDFM, let's say in your OSCEs, certainly the first things that you should do is to clarify symptoms, like asking whether there's pain, etc., etc. So I think some of your colleagues have been asking about whether it could be pain and all that, which I think is good questions. But otherwise, I think I'll hand over now to Dr. Ramani.
Hi, good afternoon again. Thank you for a very good presentation. I must say I enjoyed both talks very, very well. A few small comments first if I respond to your questions. Firstly, a few things to be helpful would be whether people who have carpal tunnel at times say they wake up at night with fingers tingling, or while they use their hands at other things, holding a handphone, reading the newspapers, they may give you some idea that the symptoms actually are related to compression at the wrist. So very good that you mentioned that during your talk as well. Very good. Secondly, during examination, do consider a few additional examination tricks which may be helpful. One is compressing the median nerve at the wrist. This direct median nerve compression at times can trigger off a similar symptom. So do consider that as a useful clinical thing you can do in the clinic. The Tinel sign at the wrist is helpful for median nerve. The Tinel sign at the elbow, where the ulnar nerve goes under the olecranon, is also another helpful sign for ulnar nerve irritation. So these two in the clinic will be helpful for you to give further idea whether it's median nerve or ulnar nerve, whether that procedure, that maneuver, brings on the symptoms that the patient is complaining of. The next thing about clinical examination is to looking for numbness, something called the finger split sign, which you may have mentioned, I didn't quite hear it. You feel take your finger, your hands, use your both index fingers and rub on either side of the person's fourth finger. So if you were to do that, you may find that if you just have the person's fourth finger, just rub on either side. They tell you, yes, doctor, on the inner side, I feel it very well. On the outer side, I don't feel it so well. You chose the split because the median nerve is supposed to split its innervation of the fourth finger to be the ulnus. The lateral side is more median, ulnar side more middle side more ulnar. That finger split signs be quite good to tell ulnar from median. Another helpful point at the bedside. Okay. My next comment comes to the issue of treating the patient with injections. Well, there's a bad thing happened in the law courts recently, so be very careful about that. But just to mention that there was a nice trial published in the Nuclear Medicine not too long ago, was it JAMA, I can't recall now, of just a simple saline injection, not even steroid, just saline alone helped many people. So some have gone to doing that. But I agree with you, it's only after everything else has failed before you do something as almost minimally invasive as something like this. Right. Nerve conduction studies, yes, very helpful. Just to mention that it's quite good, but in very mild CTS, it can be negative. And sometimes those have no symptoms, we pick up CTS signs on the nerve conduction study. We're looking basically for slowing of conduction across the wrist, either in the latency or in the sensory component of the median nerve for carpal tunnel. If it's ulnar across the elbow, we may find that slowing of velocities proximal and distal to the ulnar groove. The EMG is helpful, especially when looking for prognosis. For those who have very bad carpal tunnel, very bad ulnar neuropathy, we put a needle in, we see denervation signs, and that is not a very good prognostic sign. Some would say for carpal tunnel, once you find denervation, it's quite a bad disease and therefore may push with surgery. Those have pure sensory, the mildest. Mild motor, well, don't rush too much. Once denervation, some would say let's do something more aggressive for the particular patient. The issue of referral, yes, is an important point, but I think that is only numbness and you think it's most likely median or ulnar is probably enough to manage in the clinic. But once you see wasting and obvious weakness, maybe it's better to refer for the median or ulnar neuropathy. Whether you do hand surgery, orthopedic surgery, whoever you feel can do the treatment well, but I agree if they fail conservative therapy, do refer on. When it comes to cervical myelopathy, be surprised how surgeons are very careful. They don't operate very quickly for myelopathy unless the pain is unbearable or there's severe weakness and wasting. Many patients with conservative care, actually their power improves a bit with time and the numbness can go away and they have good control of their pain. But once they have myelopathic symptoms, bladder, bowel, low limb weakness, it becomes an urgent phenomenon. But if it's a radiculopathy, a cervical radiculopathy, then they're more conservative. Even when there seems to be quite fairly severe disc encroachment of the nerve root. Also can share with you one way of not doing surgery is to let the pain specialist inject into that localized lesion steroids. And that local injection of steroids at times helps the pain go away while the pain goes physiotherapy. A small advice I've learned from over the years, for those that have pain, not numbness, those that have pain, acupuncture can be quite good to relieve pain. So don't discount acupuncture too quickly. So that's for focal neuropathies, median, ulnar, and radiculopathy. For those with peripheral neuropathy, they have the hand as a presenting symptom is very rare. Often it starts in the lower limbs first. They have, like you've seen diabetic patients who say, I'm walking on cotton, I don't seem to feel the ground so well. Then later it comes more proximally, and then comes the upper limb. So to have the hand as the primary symptom of something affecting the peripheral nerves must be rather uncommon. For autoimmune processes, they often cause not peripheral neuropathy per se, but more multifocal neuropathies, one nerve here, one nerve there, as a part of the illness. It's seldom the first symptom of the illness. The SLE, Churg-Strauss syndrome may present first with that primary illness. Then, by the way, doctor, my hand is weak. Or by the way, I'm dropping my foot. Then you'll go into that. But from the word go, you probably will not chase that. A word of things I've learned from my practice. Many Indians from India are vegetarian and many have low B12. And those may present you with carpal tunnel as a manifestation of their silent underlying neuropathy. So when you see a patient with nerve problems, do ask your Indian, especially, are they even the Chinese, many elderly Chinese also are Buddhists, they don't take meat. They may have low B12. Ask them, are you vegetarian, as a specific question. Anyone you think has neuropathy, you'll be surprised how many will say yes, they are. And now we are becoming more conscious of not eating meat in the world. You probably will see more and more in your career. Thank you for a very good presentation. I really enjoyed it very much.
Thank you, Dr. Ramani. Perhaps I have one more question. Could you perhaps advise on or let us know about your experience with using oral steroids for carpal tunnel syndrome?
Yeah, I have not used it much, to be honest, and some do use it. The continuous steroids is a bit of a whack. If you use it, must be a short course, if at all. I've not done it myself, except for 1 or 2 patients a long time ago. Many get away without needing it. The methods you mentioned just now tend to go pretty well. Whether it's avoiding the wrist use, like you said here, splinting at the night, and the OT can give them gliding exercises. Those exercises themselves make the pains go away. Many GPs use steroids first. If you do it, it's only a short course because the underlying problem tends to remain. So they don't solve this underlying problem, steroids not going to make it go away completely. So I guess if very numb, you could do it. Start having weakness, maybe it's the steroids is already a bit too late, and I would go on to something like getting a hand surgeon to see or the neurologist to see for further assessment. Do remember that once there's wasting, doesn't always mean ulnar. Like you said, the T1 nerve root can be caught, there'll be other things going up more proximally. So once you see wasting, I wouldn't start the steroids, quickly refer the patient.
Okay, thank you, Dr. Ramani. Yeah. We do have other questions. Like what can we do in the clinic if the ulnar nerve is involved?
Yes, very similar. In those of ulnar nerve involvement, again, you ask yourself, is it part of a focal ulnar neuropathy or part of a generalized neuropathy? You always ask in every patient that you see. So in that setting, the same thing you've done is to avoid those postures that tend to cause trouble. Many people, when they use their computers, rest their elbows on the table. When you put your elbow on the table, quite often you crush the nerve at the ulnar groove. So be careful about that. So tell them to avoid that particular posture. And go ahead, try your nerve supplements. It's really fine. But once they start having wasting, then I would ask them to be referred, or weakness, ask you to refer. Sure, Neurobion, Principi Fort, Pure B12, and now alpha lipoic acid is also in the market. You can try that as well, and all that seems fine. Once you have weakness and wasting, then I would ask you to refer. Do bear in mind that there is a variant of motor neuron disease that affects largely the T1 nerve root. We see it largely in Singapore, C8 and T1. And they may present as boys want to go to the army. The doctor, I can't quite write well, and you see wasting and weakness of the T1 muscles, and including at times the flexor compartment of the forearm. So you see that, then you must think there's no sensory symptom. It's only wasting and only weakness. Do think of this uncommon condition of a focal variant of a motor neuron disease. So bear that in mind. In the meantime, Neurobion is fine. Don't have to rush to refer to anybody. Many will get well with nerve supplements and with care, not to compress the ulnar nerve too much. Thank you. Yes, I think for carpal tunnel, Neurobion can certainly help, and many people do help with Neurobion or other B supplements, or even the use of alpha lipoic acid. That's fine. But once you have weakness, wasting, I think you should start referring. Otherwise, you can start with conservative first. If the pain is very severe, numbness very severe, yes, gabapentin, pregabalin tend to help them. But do bear in mind, these medicines are a bit sedating. So do warn them of this side effect of pregabalin or gabapentin. Please start low and go slow as you gently escalate the doses. But again, wasting or weakness is an indication for referral. Thank you.
Okay, thank you very much, Dr. Ramani. That was very enlightening. I think if there's no more questions from the class, then we will just close off this presentation. Thank you once again, Dr. Ramani.
Oh, thank you very much. I see a thing about double crush.